they were going behind, and this thymus, it has to go down to the mediastinum to reach to its final shape. Now the parathyroid cystogenesis, third and fourth pouches, they proliferate during 5th week, and then they migrate inferiorly and medially, and then they differentiate chief and oxiphyal cells. Ultimum branchial body is the thyroid, and that is responsible for parafollicular or C cells, which give rise to calcitonin, which is responsible for metabolism of calcium. So these are the different conditions which are associated. These are the anomalies which are associated with the development of the thyroid gland. Accessory thyroid tissue can be found anywhere. Ectopic thyroid gland, not in its usual site. Congenital hypothyroidism, thyroglossal duct cyst in the sinuses, and agenesis of the thyroid gland. So all these possibilities, they are possible and they are there. They have their individual preferences. But right now I'll be focused more for 2-3 more important conditions. What are they? The ectopic thyroid gland. So thyroid gland can be seen at unusual sites. What unusual? Excuse me. If you know it, you may leave us. I need not to remind you again and after. So now you can see in the passage of this descent of this thyroid gland. Now this place is the most common site where you can see this lingual type of thyroid at the foramen cecum. So this accounts around 10%. But if it doesn't lodge at these probable places, it can enter into the mediastinum behind the sternum, and that is the retrosternal type of thyroid thing. And then once it's there, and if that thyroid got enlarged, it causes superior vena cava syndrome and all those things, because it is compressing upon the major vessels onto the superior vena cava. So all these collateral channels, they'll start functioning and they will come into different shapes. So the ectopic size of the thyroid gland, it's a must-know type of thing. Well, I'm not saying every condition you should be familiarized with, at least the names, but this ectopic thyroid gland, it's a situation which you might come across. Now here, the thyroglossal duct cyst and the sinus, you have shown the mechanism during the formation. Remember, in your surgical postings, you will be asked and you will be able to understand the neck swellings. And there you should be knowing the central, the swellings in the midline, and the lateral swellings. And then all these swellings, they have different characteristic things. When you will be doing your pediatrics rotation, there you might see these conditions. They are quite pertinent and quite common. Saad, what special message you are getting? Now, this condition, a solitary nodule, if it appears in a thyroid gland, this is a hallmark. This is something where one should be very suspicious. It could be a malignant variant, so one has to go for it, at your level, because pathology is not my subject to start with you, and then surgery definitely I will not like to go to that extent. But the ultimate thing is, after having all the evaluation of thyroid function tests, one should go for fine needle aspiration to see what really it is to reach to, because these solitary nodules, it could be a hot nodule, it could be a cold nodule, and then there are so many things which are associated. So this condition should not be ignored. Khalid, what's your question?
This isn't called a goiter?
Goiter is different. This is just one solitary node which is appearing in the substance of the thyroid. It's not goiter. Goiter is generalized swelling. It's just a solitary thing. Now guys, you can see here, this is the neck, this is the tongue, oral cavity has been opened, and you can see here, what is this? This is the lingual, this is one of the ectopic lingual thyroid, which is the most common out of these ectopic sites, right? So this is quite prominent here, and you can see it.
What is it again?
Lingual thyroid.
What is it?
Where is it? You are sleeping in the previous slide. I can show you this one. If thyroid doesn't descend down and it stays here, then this is called lingual thyroid. Incidence is 10%. Okay? So now there goes. Goiter you can see. Alright, now you can feel the difference. See how big and how different they are. Now this lady, thyrotoxicosis, and you can see exophthalmos, you can see the signs, you can see all the features under microscope, her tissue, yeah, PPL case. This is that lady and this is all what you are interested in. So all these things are associated. This is a young lady, that was an old lady, but she also have exophthalmos and all those signs. And you can see this weight loss, increased appetite, irritability, diarrhea and everything is here. And then these are the signs. So all these things, and this is how people, so Graves' disease. So all these features are fitting in your case, which are about, I think that you have done it. You have taken it? So enjoy it. Now this is a goiter. So you can see, I have discussed this slide yesterday also. This is a huge goiter and it has, excuse me, if I every time I have to remind you, stop and all that, am I dealing with kids? Exactly? Then probably go to some Montessori grade or some other place. So just be focused. If you are not interested, you have marked the attendance, you have a free ride, you can go out. I have no problem. So if this goiter thing is compressing upon different organs, these are the effects which are generated. You have not marked it, so you are still stuck up. So thyroid follicle, what is that? They are spherical cyst-like and they are lined with cuboidal epithelium and they contain colloid. Colloid is a gel-like substance and there are two types of the cells. We had follicular cells and parafollicular cells. The follicular cells, they are responsible for secretion of T3 and T4. Under microscope, they are slightly basophilic basal cytoplasm with spherical nuclei, rounded nuclei. This is how they appear under microscope. And these parafollicular cells, they are also called C cells. They are responsible for the secretion of calcitonin. And these cells, they are located in the periphery. You can see in this picture. They are located in the periphery. They are in clusters and they have pale staining under microscope. So it is difficult to see these parafollicular cells with light microscopy. Rather, we need to look at under the electron microscope. We are very strong, focus, and then we can appreciate the different characteristics. So under microscope, this is how the appearance of this follicular and parafollicular cells. And you can see this follicular cell. I have an extensive picture of that. That shows you this follicular cells, a small segment. So what is happening here in the follicular cells, and how this whole of this iodine, it is being uptake and then this process going on. In the colloidal material, these changes are occurring and ultimately we have the production of T3 and T4. So this is how it is being carried about. This is the mechanism behind whole of this exercise. Now, under microscope, thyroid has a very characteristic appearance with this colloidal material. There is no other slide which have the there is no other slide which have this big quantity of this colloidal material and these lining epithelium, the cuboidal type of epithelium. This is a characteristic for being a thyroid tissue under microscope. So there should not be any doubt where you can mix this slide with any other slide. Okay. Now these are the different pictures of the same thyroid tissue under microscope. These all 4 are from Wheater, so you can consult there if you have problem with identification of these things. Now this is a simple labeling. You can see the colloidal material, epithelial cells, and they are low cuboidal. Now this is a detail. If you don't want to open your book, go through this text. So now parathyroid gland, it comprises of what? Chief cells and optimal cells. And you can see how they are present, and basically they are arranged, these cells, they are arranged intrathecally within a stroma composed primarily of adipose tissue. So there is abundant adipose tissue, pale looking segments are seen in this thing, and you can see under microscope the appearance of, this is how the oxyphil cells and the chief cells they look like, and you can differentiate very clearly with the thyroid and the parathyroid thing. And that's all.